Thanks for tuning in to my presentation today. My name is Dave Hashi. I'm a clinical professor at Iowa State University. And today I'm going to be presenting on the acute side effects from antiretroviral medication. And it seems like almost every day we are exposed to literature, whether it's in the lay press or in the medical literature, about drug adverse effects. And because drug adverse effects are a major limiting factor in achieving therapeutic outcomes, regardless of the disease state, as providers, we really need to effectively balance that relationship between tolerability of drug regimens and achieving therapeutic outcomes. And that's what I really hope to focus on today, and hope that you come away with is identifying these acute side effects from antiretrovirals, usually what we see in the first few months. I'll be following this presentation up with another one on chronic side effects. So I have no relationships or financial ties I need to disclose, even though I sometimes wished I did have financial ties. But anyway, again, what I really want for you to get out of this presentation today is not only to identify these adverse effects from medications, but is to develop appropriate management strategies. As some of it may be as simple as riding the storm out, and others may be more severe course of treatment needing ICU admission or IV therapy. So with that, the most common adverse drug effects that we see are gastrointestinal, dermatologic, and CNS in nature. So those are the ones we're really going to focus on today. But before I get to those specific conditions, I wanted to talk briefly about general adverse drug effects from antiretrovirals. It is still the #1 reason why patients switch regimens, whether they need to discontinue or start something new or have a drug substitution. The intolerance that some patients have, or the sensitivity that some patients have to these medications, can be very severe. Despite the fact that side effects have declined, or the severity of side effects have declined with the newer agents that have been introduced over the past decade when compared to medications used back in the 80s and 90s. The other positive feature of adverse effects is that we are seeing few of them because we are starting patients sooner on therapy, meaning we're starting patients on higher CD4 cells, CD4 cell counts than what we used to. And when patients have low CD4 counts, specifically lower than 200, they may be at a greater risk of developing an IRIS, or an immune reconstitution inflammatory syndrome, where the immune system, as it's restoring itself, is wreaking havoc on the body, and it may be difficult to tease out whether there's an acute adverse effect of the drug or there's something else like an IRIS going on. Additionally, we may see higher rates of adverse effects in other patient populations that aren't necessarily accounted for from clinical studies, those being specifically women and older patients. Women have higher rates of rashes, hepatotoxicity, lactic acidosis, where older patients may also be a bit more sensitive to some of the drug side effects and not really have the compensatory mechanisms to adjust for some of those side effects. And lastly, many medications will have overlapping side effects or toxicities between the antiretrovirals or with other conditions. So for example, although a single drug may have a 5 or 10% likelihood of causing a rash or causing nausea, when added to other medications that cause rashes or nausea, it can have almost an additive effect. And then trying to decipher which medication causes that effect can be more difficult. And finally, when patients have other disease stages such as the use of alcohol or hepatitis, some of these adverse effects may be a bit more pronounced as well. So the emphasis or the focus point of this presentation is really the take-home points of how you can educate your patients about what to expect for potential side effects and how to manage those side effects to get them adjusted to new therapy. Because nobody likes to start and stop medications, so with that, really providing tools to your patients can help them achieve good therapy outcomes. Gastrointestinal side effects tend to be the most common problem seen with antiretroviral therapy. And of that, diarrhea is probably the most common. And when we looked at the spectrum of diarrhea in patients with HIV, it can happen from the onset in acute seroconversion to late stage AIDS, and can also be caused by antiretroviral medications. And the etiology of all these effects can be quite problematic, or problematic to decipher. And what I mean by that is a patient may have progressed immune deficiency, and because of the depletion or the viral replication within the intestinal tract and the involvement of the CD4 cells within the intestinal tract, maybe having diarrhea from that. Then when antiretrovirals are added, those can aggravate or irritate the intestinal tract, leading to more diarrhea, and can be difficult to decipher what the true underlying cause is. So with that, keep in mind when evaluating patients that it's a full spectrum of that diarrhea is related to the full spectrum of the disease from acute infection. Because of that, there's also differences in severity. Patients may have a mild presentation with only mild loose stools to a severe presentation with 6 to 7 watery explosive episodes of diarrhea a day. And the thing to really take away in deducing on whether or not it's a drug-related side effect is, first of all, is the timing associated with the introduction of the agent. These drugs can have adverse effects within a few days, and it's most commonly associated with the protease inhibitor class of medication. The lopinavir-ritonavir combination has greater propensity to cause diarrhea when looked at or when compared to darunavir or atazanavir boosted regimens. Now, if you look at the common denominator in all those combinations, ritonavir is still one of the biggest contributing factors. And when you look at some of the rates of diarrhea, it can be as high as 25%. However, a lot of those original doses were 4 to 5 times higher than what we actually use today. So certainly keep that in mind. And then lastly, there's also some post-marketing data that suggests raltegravir may be associated with some mild diarrhea as well. Now, assuming that all of the causes have been accounted for, and that the diarrhea is associated to drug therapy or associated with drug therapy, management of this can be as simple as emphasizing or educating the patient to take the medications properly. Some patients will take them with or without food, but lessening diarrhea, for the most part, can be achieved by taking medications with food. The only exception to this would be would be efavirenz, and efavirenz-based regimens should be taken on an empty stomach, as taking them with food can increase absorption too much. Also, assessing hydration status of the patient if they're having severe watery diarrhea and are not able to keep up with their hydration status. That should be assessed as well. As far as management of the diarrhea, mild diarrhea a lot of the time can be taken care of by over-the-counter agents such as loperamide or Imodium, bulk-forming agents such as Metamucil. There's also some data to suggest that oat bran tablets can help as well. And finally, calcium tablets such as Tums has been shown to reduce frequency of diarrhea. If those do not work, then access to prescription medications such as Lamodal or diphenoxylate and atropine can be used, and then also Wellcall has some good data to support its use in treatment of diarrhea induced by antiretrovirals. And because of that, it also may help with cholesterol, which sometimes can be a significant barrier in patients with HIV. Other GI complaints seen with antiretrovirals include nausea and vomiting, and these are side effects listed in every class of medications. So again, there may be additive effects or overlapping toxicities that really need to be taken into account of, and it is seen, when you utilize all medications or medications from different classes. So the PIs, or the protease inhibitors, are more notorious of causing nausea and vomiting than your nucleoside reverse transcriptase inhibitors, and to a much lesser degree, your NNRTIs and your integrase inhibitors can cause some nausea and vomiting, but much less likely. So as far as nausea, as previously mentioned, medications more or less can be taken with or without food. Again, efavirenz is the only exception. Efavirenz should be taken on an empty stomach. And so you can minimize the side effects by taking them with food. Another approach is by taking the medications at bedtime. If patients are having mild nausea, they sometimes can sleep through that if they take their medications at bedtime. But if patients continue to have nausea despite all of these lifestyle changes, the use of antiemetic medication can be used safely. Compazine or prochlorperazine are inexpensive and effective, and but sometimes patients may need something a little bit more potent, something along the lines of ondansetron or Zofran can certainly do the trick as well. And then lastly, with nausea, if weight loss is an issue, the use of certain appetite stimulants can certainly be employed, and whether your state supports the medical marijuana or the use of Marinol or Dronabinol, that can sometimes help with nausea as well as increase appetite. Now, something that's a bit more severe is vomiting, and for a couple of reasons. One, vomiting certainly can lead to dehydration and other electrolyte abnormalities. However, if a patient vomits soon after taking their medication, the medication may not be absorbed. If it doesn't get absorbed, then it can't have its clinical effect. Therefore, vomiting needs to be addressed more acutely and more aggressively. And with that, similar approaches of use of antiemetic medications can be employed, but in severe cases, patients may need to have their medication switched to a different antiretroviral so that they can overcome that vomiting. Now, general rule of thumb is to allow 15 to 20 minutes for medications to absorb after they're swallowed. So if a patient vomits, usually within 15 minutes, they should be redosed, but anything greater than 15 or 30 minutes usually is adequate enough time for patients to absorb their medication. Hepatotoxicity is probably the largest, the biggest concern from a gastrointestinal standpoint, and hepatotoxicity from antiretrovirals is probably the most severe complication. And historically, HIV meds have been notorious for causing some of these problems and actually carry a lot of black box warnings. Now, of all the agents that are out there, nevirapine or nevirapine carries the largest risk in the NNRTIs. It's often associated with rashes or hypersensitivity symptoms, and those should be addressed very quickly, as the rash may coincide with the hepatotoxicity. And a subset of patients have been identified for a greater risk of hepatotoxicity. Those include treatment-naive women with CD4 cells greater than 250 and men with CD4 counts greater than 400. So it's generally recommended to avoid the use of nevirapine in patients with elevated CD4 counts. Another way to reduce the risk of hepatotoxicity is to titrate the dose initially over the first 2 weeks of therapy by giving 200 milligrams once a day, then increasing to 200 milligrams twice a day, or switching the patient to an extended release formulation of 400 milligrams once a day. Patients on protease inhibitors can also carry a bit of a risk of hepatotoxicity seen through the channels of drug-induced hepatitis or hepatic decompensation. But more specifically, one that is seen on a much more frequent basis is jaundice from atazanavir due to hyperbilirubinemia. So it's very common to see patients have elevated bilirubin levels, and generally letting patients float up to and around bilirubin levels of 4, but once they start getting elevated above that or symptomatic, patients really need to be switched to a different antiretroviral. Our nucleoside reverse transcriptase inhibitors have an association more so with the older agents as opposed to the newer agents. However, be very careful in patients who are co-infected with hepatitis B. So if you remove some of these agents that do have antiviral activity against hepatitis B, if you remove that, you may get a flare of your hepatitis B during that time. So that needs to be considered in patients co-infected with hepatitis B. So general approach or management to hepatotoxicity, again, any type of abdominal pain with elevated liver function tests should be addressed promptly, and drugs should be high on the differential list. So whether or not you need to discontinue antiretroviral therapy or switch it really needs to be discussed, and those risks and benefits weighed out. And lastly, asymptomatic hyperbilirubinemia, it's perfectly fine to let patients run between 2 and 3. However, once they start getting up to 3 and 4, really should be examined for switching in therapy. So let's transition over to dermatologic presentations of drug adverse effects, and dermatologic presentations are common across the spectrum of the disease. And again, it can sometimes be difficult to differentiate between infections, immune reconstitution syndrome, adverse drug effects, and the other run-of-the-mill skin conditions unrelated to HIV. So again, having a good relationship with dermatologists can greatly help you in your evaluation of skin reactions. But let's look at a few of the most common. First off are non-nucleoside reverse transcriptase inhibitors. Skin rashes are extremely common within this class of agents, and with that, the spectrum includes minor single erythematous lesions all the way up to Stevens-Johnson syndrome. And This, for the most part, is seen usually within the first 6 weeks. Liver function tests are usually elevated during this time as well, so those should be jointly examined. Um, General treatment approach is that minor reactions can be generally treated with antihistamines. However, for Stevens-Johnson's or more severe reactions, determining whether or not all agents, well, first of all agents should be removed if Stevens-Johnson is suspected. Patients should be treated symptomatically and supportively, whether that requires hospital admission or close outpatient monitoring. And generally, to minimize these side effects, we really want to, again, dose escalate the nevirapine from 200 milligrams a day for 2 weeks up to 400 thereafter, 400 once a day or 200 BID. Skin reactions from protease inhibitors are also common. Up to 10% of patients can develop rashes from protease inhibitors. Atazanavir, darunavir, and fosmanpremivir can all cause these rashes. And the major problem that is seen is in patients that have a history of a sulfonamide allergy, and in part, these agents, specifically darunavir, has package labeling stating to be cautious in use with patients with a sulfonamide allergy, as there may be some cross-sensitivity. So just be careful with that, but again, there isn't anything, unless it was a life-threatening hypersensitivity, that otherwise patients can be closely monitored. Very rarely Stevens-Johnson has been reported with the protease inhibitors, but extremely rare. And then lastly, with the nucleoside reverse transcriptase inhibitors, abacavir is the most common drug associated with rashes, and there's specific hypersensitivity reaction associated with abacavir that may include one of the symptoms as a diffuse maculopapular non-pruritic rash, in addition to other symptoms. It can be head to toe, on the palm surfaces, and the thing to note is that it usually does occur in the first 6 weeks of therapy, but has been known to pop up throughout therapy, at any time. And because of this, we can genetically screen with the HLA-B5701 test. This is recommended by the DHHS guidelines that any patient projected of starting abacavir be screened with this test, because if it is positive, then the patient has a greater likelihood of developing this reaction. If the patient does not have this genetic test, or does not have this genetic predisposition, then they have a much lower likelihood or risk of developing this type of hypersensitivity. And then lastly, tenofovir, tricytidine, and zidovudine may all cause mild skin reactions. And lastly, in respects to skin reactions, immune reconstitution has to be taken into account in your differential. If patients do develop certain skin reactions, seen here is a patient after 8 weeks of starting antiretroviral therapy developed herpes zoster as part of their immune reconstitution. So patients who have extremely low CD4 cells, as their immune system starts rebuilding itself, you can see activations such as this. So again, keeping that in mind, when you do see immune reconstitution, that mild symptoms can generally be managed with NSAIDs and continuing antiretroviral therapy, as opposed to severe symptoms in which steroids may need to be employed. Now lastly are the CNS adverse effects that I want to emphasize, and we sort of differentiate these two into a couple categories: general CNS effects, as well as our neuropsychiatric side effects. So, general run-of-the-mill adverse effects can be seen in all classes of antiretrovirals, primarily with headache. major complaint. And again, these effects may be additive when using agents from different classes, and identifying the offending agent can certainly be difficult. Management of headache, again, assuming that all other causes such as toxoplasmosis, meningitis, all other things have been ruled out in as far as non-medication causes. Treatment can range from OTC agents such as Tylenol, other NSAIDs, all the way up to stronger narcotics if the patient needs to try to stay on that therapy. However, sometimes if it's available, switching regimens to find a less likely offending agent is an option as well. However, rarely comes to that. Now, neuropsychiatric side effects are seen predominantly from efavirenz, and efavirenz is a non-nucleoside reverse transcriptase inhibitor. It is first-line DHHS guideline recommended agent in combination with emtricitabine and tenofovir. The thing about this medication is it does cross the blood-brain barrier and can cause more CNS effects. It can cause dizziness, insomnia, vivid dreams, impaired concentration, drowsiness, and with this, it is usually seen in the first few days of initiating therapy, peaks at about 2 weeks, and then begins to taper after about 2 to 4 weeks. So patients really need to be supported through the first month of therapy when they start a triplet. And of note, there is risk of activating or reactivating underlying psychiatric problems in HIV patients who are started on this medication. So again, really based on some of the available data, it really should be argued that efavirenz should not be initiated in patients who have either active, uncontrolled psychiatric illness or severe sleep disorders. So again, patients with a history of psychosis, mania, suicide ideation, anxiety, all of these can be worsened with therapy and needs to be, if this agent is going to be selected, these patients need to be actively monitored and closely monitored and have a plan in place should some of these symptoms begin to rise. So to tie it all together in respects to first-line DHHS guideline recommended regimens, efavirenz-based regimens, you really need to be cautious about the CNS effects that we just discussed, as well as rashes that may present. Atazanavir, when used in combination with ritonavir, can cause nausea, rash, abdominal discomfort, as well as the elevated bilirubin. Darunavir, when used in combination with ritonavir, can cause diarrhea, nausea, potential sulfonamide rash, so be careful of that. The nucleoside reverse transcriptase inhibitor backbone of tenofovir and emtricitabine can cause headache, fatigue, nausea, and lastly, ritonavir, which is used to boost atazanavir and darunavir, can cause nausea and diarrhea, as well as have some additive effects. Finally, remember that these acute side effects are common, but many will resolve as therapy continues. So really being able to identify and differentiate these acute effects, these acute side effects, is a really key clinical tool, and also being able to identify patients who may be at higher risk for adverse effects, again, such as female patients, older patients, patients with other comorbidities, and really emphasize focusing on an appropriate regimen will help you, again, lessen the likelihood of adverse outcomes. And finally, through the use of education, appropriate follow-up, constant contact, and providing tools to your patients can overcome these problems and really help ensure therapy, best therapeutic outcomes for your patients. So good luck and thank you.